You can hear me good, Tian, I hope?
Yes.
All right. Let's see. Can you share my screen for me? Where do I do that? Here we go. You can see my screen now, fine, Tian?
Yeah, all good.
All right, perfect. Good morning, everybody. Sorry for the short delay. Privileged to be back here with you again. As Tian said, general surgery at Weill Cornell, New York City, cardiothoracic at Cleveland Clinic, and I have the privilege of being the chief of thoracic surgery at St. Francis and St. Mary's in Connecticut. I have been a robotics consultant for Medtronic as well as Intuitive, although that was in the past. All right, so I'm just basing this off of the SCORE curriculum. There's going to be lots of material. This shouldn't be anything new. At this point, maybe some of you are newer. Maybe the first and second years are still, introduced to the whole nature of the ABSITE. The best way to prepare is really doing more questions. And then taking the time to make sure you understand why the wrong answers are wrong. So really, if you spend like 1 to 3 minutes on a question, have that background, you can face the, when those questions come up in different iterations well. And then using the internet too, to look at images that are representative of those findings. There's just such a wealth of information. You need to be kind of more astute at how you use that to prepare. A word of caution with regards to AI. I myself do use AI quite prolifically, especially in administrative tasks, and it's been a great help for that. I have found when asking it medical questions, because it gives equal weight to old information, sometimes it is not able to kind of give the most appropriate answer. So just take that grain of salt if you're using AI to study, because it can definitely lead you in the wrong direction. Whereas, in medicine, we're trying to look at what's the most recent papers. AI can't weight that, and it's definitely tries to give credence to the entire body of its understanding rather than what's most current. Okay, so starting with esophageal anatomy. Why is this critical? It's really critical understanding how do you manage the various aspects of what presents within thoracic surgery and just the esophageal problems that we'll be faced with, and what are the best surgical interventions, right? As surgeons, we're typically interested in which surgical intervention will give the best outcomes and how to best address that aspect to it. So whenever we're measuring the esophagus, we always start a distance from the incisors, right? So typically, the upper esophageal membrane, upper esophageal sphincter is going to be somewhere around 15 centimeters. So kind of immediately posterior to this cricopharyngeal constriction we see right here. The first portion of the esophagus, depending on what different books you read, extends somewhere down to around 20 to 25 centimeters from the teeth. And that's going to be somewhere around where the trachea forms its carina as well as the arch of the aorta. So you should see some sort of notch from the aorta at that point in the esophagus. And then the middle third is going to be in that region of 20 to 30, and then 30 to the end will be the distal third. And this is critical in understanding, where and how we access, right? Cervical portion is going to be somewhere here in 15 to 20 centimeters. The thoracic inlet is somewhere around 20 centimeters. Again, 25 centimeters being the arch of the aorta, as well as the carina, and then the rest of the portion is kind of intrathoracic esophagus. And depending on the person, your diaphragm can be anywhere from like 35 to 45 centimeters, depending on the size of the person. Important, right? Because, type 1, in terms of what do we most commonly see for foregut surgeons, is really how do we discuss this hiatal hernias and how do we repair them? So a type 1 hiatal hernia, the GE junction we see here, which is again just immediately distal or at the level of the diaphragm, is sliding above the diaphragm. So that is, you really just have this border right here above that level. A type 2 can be considered a paraesophageal hernia. The GE junction can be at that normal position, but the body and the fundus of stomach is now sliding up into the chest, which clearly is going to create some issues with eating. A type 3 is going to be a mixture where the GE junction is displaced, but portion of the stomach is also above the diaphragm. Again, critical for understanding the degree of the repair. Could there be an aspect of a foreshortened esophagus, whereas you may need to do additional procedures like a collis gastroplasty? Additionally, in terms of, and we'll talk about this again, esophageal cancer location, right? Cervical esophagus. It's rare nowadays that we're going to treat that with just a simple Ivor Lewis, where the anastomosis is going to be somewhere in this region over here, right? 25 centimeters. It's going to be difficult because you have to do a lot of neck dissection. If the tumor is in the neck, it's very difficult to peel that off of the back of the trachea and everything else. So typically 15 to 20 centimeters, or really 15 to 24 centimeters in my experience. We're going to advocate for more a radiation-based approach because there'll be less risk of anastomotic leak, as well as, TE fistulas and the like with regards to interventions up here. And these tend to be squames, so they're much more sensitive to chemoradiotherapy. The, distal, in terms of the second portion, the third portion, that's where we really reserve with, lower incidence of anastomotic leaks, lower incidence of complications with regards to esophageal surgery. And that's where we kind of tend to have more of esophagectomy interventions. Okay, so in this picture, we see a typical barium esophagram of the stomach. And you see here, all the way up here, kind of in the thoracic chest, you can appreciate the diaphragm on this side. And there's a pinching here. Here's the GE junction, right? And here's also the pinch from the hiatus. So in my opinion, you could consider this as a type 3 esophageal hernia because you have the GE junction so far above the diaphragm, as well as a good portion of the stomach, right, is already into the chest. So again, reviewing typical images that you see, they love giving these X-ray images, what is going on here, and then what is the appropriate treatment. A laparoscopic, transabdominal, or even a robotic approach to a paraesophageal hernia repair with fundoplication would be probably prescribed. Okay, so when we're examining and discussing, a patient with a hiatal hernia, what is their typical presentation? A patient who has upper abdominal discomfort, we always, the discomfort can be substernal chest pain, it could be a substernal pressure, it can be epigastric pain. So we're worried about things like volvulus. Is it just simple reflux? Is it bleeding from Cameron's ulcers, right? The mere pressure of the diaphragm on the stomach can cause chronic ischemia to those portions of the stomach, developing Cameron lesions. All right. So with a paraesophageal hiatal hernia, we typically see some element of gastroesophageal obstructive symptoms. Could they be dysphagia, where a patient has difficulty swallowing? Could they have pain with swallowing, meaning they try to eat something or they have some steak and they develop severe substernal chest pain, maybe for minutes, maybe for hours, or as in the case of sometimes we see where the entire stomach is in the chest, the patient's been, just chronically small, can't eat very much because they get full very quickly, which we describe as early satiety. So having in the back of your mind, right, we're trying to be this octopus arm of like, okay, we have 8 different diagnoses and we quickly knock them off as to what is the diagnosis with regards to this case and what are the critical factors of understanding within the pictures and the description, and then where do we give weight within the question on the ABSITE, the greatest amount of room that is kind of the focus of answering with the best answer to the question. All right. Other symptoms that can be associated with a hiatal hernia, especially when it's within the pleural space, that is, instead of being, in this picture we saw previously, this is more of a central aspect. There could be some pressure on the left atrium because, again, the stomach, right, is behind the heart in these hiatal hernias. And we'll talk about some other images laparoscopically about what we should be dissecting towards. But you can have respiratory symptoms when the stomach is more into the left or the right pleural spaces. Usually the stomach will go more into the left side. It's just easier because of the location of the anatomy. And so you can have respiratory symptoms such as shortness of breath, from especially associated after meals. Obviously, we're kind of just running the gamut as to the different symptoms here. So just things need to be put into place within your differential diagnosis, and then incorporate a barium esophagram or upper endoscopy, or the typical, lower invasive tools we have to make that diagnosis. Okay, If a patient is presenting with a constellation of symptoms of dysphagia, chest pain, and emesis, you need to include the understanding of a paraesophageal hiatal hernia that is incarcerated and could have aspects of gastric volvulus, could have a threatened stomach. And so your timetable, right? Because many times we encounter these paraesophageal hernias, they're long standing. They've been there for a long time. The patient's been tolerating it. But we need to differentiate in that workup between one where the stomach is threatened. Okay. And so dysphagia, chest pain, and emesis within the ED that is significant to a point, we have to say, okay, is the urgency here greater? What is the best way to treat those, and how do we make the diagnosis quickly and without much ado? So a chest X-ray, obviously, if we see a large gastric bubble within the chest, that should predispose you to have hiatal hernia much higher in your differential. A CT scan can be obtained, hopefully with oral contrast. I'll just note in my own experience, I had a patient who was presenting with shortness of breath. Now, underlying this is a male 50 years of age with early onset Alzheimer's dementia that was quite severe. And it was difficult to appreciate how long he had these symptoms. And so when I got the x-ray noting the gastric bubble and having factors of perhaps some hypoperfusion with an increased lactate, we had to just immediately go to surgery. The crazy part was when I got there, I found that he had only a type 2 paraesophageal hernia where the stomach, right, the fundus had been constricted chronically. And actually what had happened, the reason why he had hypoperfusion, the stomach had been dead for a day, but because of his underlying Alzheimer's, it was something that was ignored. So again, that's more of a clinical thing that you may experience as an attending, but always, 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 when you see labs which are leading you in one direction, keep going down that rabbit hole, right? When the ABSITE gives you things that should be alarming to you, never minimize them. And the same thing as an attending. If there are alarming things, there's an unexplained leukocytosis, elements of hypoperfusion, concerns for early sepsis, you need to escalate your interventions rather than de-escalating them. Always be a little leery of saying, okay, let's take them to the ICU and stabilize them. Sometimes your surgery is going to be the most stabilizing, and early intervention is usually better. Not always, but keep that in the back of your mind. Okay, if a paraesophageal hernia is noted to be incarcerated, care should be taken when mobilizing the stomach in the operating room as it may be frail. Again, going back to the case of the 50-year-old man, literally I got into the stomach and part of it was the wall was necrotic. And then I realized as I scraped away a little bit, I was looking at ribs. I was freely within the chest, which had, because of the chronic incarceration of his stomach, and he had just not eaten and that sort of thing. And because he didn't complain due to his underlying dementia, it had become necrotic in the end. So in the end, what did we do? We did, basically 2 incisions. We did a laparotomy, and we excised the top of the stomach from the abdomen, brought everything back in, gave him a feeding tube. And then from the chest, we decorticated the lung, removed the necrotic tissue in order to help everything re-expand and close the large diaphragmatic defect. All right, so here we have a post-op x-ray, right? This is actually what you should expect to see after a normal Nissen, right? Nissen. We have reduced the stomach back into the chest, or there was no hiatal hernia, and this is somebody who just has, a completely incompetent anatomic complex around the lower esophageal sphincter and chronic reflux. Obviously, that's happening less and less nowadays, but it is something that should be considered, especially because there are still some presentations of patients who don't respond to, the PPIs that are so effective, especially if people have chronic bile reflux, which can also present with severe esophagitis. So here we have someone, we note the character of a kind of a normal peristalsis proceeding down. We see the diaphragm right here, and here we identify the region of where the wrap is, and there's still good and easy passage into the body of the stomach from the Nissen. All right, here we see a hiatal hernia. Patient has some aspect of fluid within the stomach. It is completely, in my opinion, within the chest, right? We can see the diaphragm They may be presenting with pressure on their heart. They may be presenting with lower blood pressure, shortness of breath. Why? There could be diminishment of, return to the heart due to the increased pressure on the left atrium. Again, multifactorial in its presentation, right? Oddly enough, there is a little bit of tracheal deviation here, which should be appreciated. All right, when a patient's been identified with it, just this is from, not so much specific to the ABSITE, but what should you be thinking of? You need to be thinking about what the complications are to the patient. If a patient is completely asymptomatic and you do a complete review of symptoms with regards to what the possible ways a threatened stomach could be, then it is something that could be treated on an elective basis. And usually these are not going to be the patients you're going to meet in the emergency room. Okay? But large hernias are always at risk for incarceration, strangulation, volvulus. Why? Because there's the ability to torse on that route. Now, the great thing about stomachs is they have such a complete and redundant blood supply. So that risk is somewhat lower. However, with the herniation, those blood vessels are actually extended, thus they're not tethering the stomach, right? In a normal anatomy, when we look within the abdomen, right, especially laparoscopically, we appreciate that those splenic vessels, right, as well as the omental vessels kind of tether the stomach so that it can't twist. But when that stomach herniates, we suddenly have additional length and there's added mobility for that potential. So respiratory symptoms, identifying again, what blood tests, what clinical factors, be it vital signs, be it laboratory factors, leukocytosis, lactate, acidosis, what other factors are elements of hypoperfusion, elements of hypovolemia that you're identifying that could suggest in your interpretation this is a surgical emergency. Okay. Continuing on this vein, in a patient with a symptomatic hiatal hernia, we always want to understand what is the preoperative workup and the indications for surgery versus continued conservative management. Okay, so just as an aside, in today's day and age, obviously bariatric surgery, there are patients who are morbidly obese who may have some aspect of a hiatal hernia. We should not think that for the treatment of their symptoms that a hiatal hernia repair, a paraesophageal hernia repair should be the first line. Sometimes it could be considered as medical management. I'll defer to the bariatric surgeons on what their algorithms are. But I know with myself, if a patient's referred to me and they have type 1, 2, or 3 paraesophageal hernia, this should be done in concert with a bariatric surgeon. Why? Well, the main thing is that there's an increased risk of recurrence. The literature does say in a case of a morbidly obese patient that a simple laparoscopic repair can have recurrence rates as high as 35%. So that should be it. And that's because of the increased intra-abdominal pressure that those patients have. So sometimes bariatric intervention should be considered before in patients who do not have significant concerns for threatened stomach or for any of those other complications. All right. You still there? Yes, hopefully. Sorry about that.
Yes.
Okay. All right. So the back one. So what are the evaluations? So the typical first evaluation should be a barium swallow as well as EGD and a manometry. In clinical practice, obtaining a manometry is a much harder thing than it is on an ABSITE app. But if you're considering the repair of a hiatal hernia, manometry is always indicated, and we can talk about some of the manifestations that we see of abnormal findings of manometry, because you want to ensure that there is no dysmotility present, because that could significantly affect your act. If you do suspect that, a lesser wrap can be considered, such as a door fundoplication or even a simple hitch. Why? Because you want to ensure that there's no chance that your wrap is going to exacerbate the symptoms of dysphagia in that patient, right? Because some patients with a hiatal hernia or a paraesophageal hernia can present with those dysphagia symptoms. Okay, so if a patient, let's say, had some sort of Bravo pH testing, has discovered they have chronic reflux, PPIs are nowadays considered the primary mode of treatment. However, if they have persistent reflux symptoms, such as, and can be considered as having failed medical therapy, then we should be considering either a toupee fundoplication or, in some instances, still a Nissen. Dysphagia, early satiety, postprandial chest or abdominal pain, anemia, and vomiting. The anemia can be from multiple reasons, such as Cameron ulcers. The vomiting can be from, again, that increased pressure and inability to simply accommodate that oral intake. All right. Sometimes we see younger patients in their 40s and 50s who have a large hiatal hernia, but no symptoms. We can recommend a reduction of that hernia because sometimes over time they can progress. Do they always do that? Do we have long historical longitudinal data? Yes, we do. But again, it depends on the center. And some centers are advocates, some advocate for more conservative therapy. I think it always depends on your success rate as well as the patient satisfaction with regards to the surgery afterwards. Okay. Type 1 or a sliding hiatal hernia should always be managed based on the symptoms of the reflux disease, right? This is a very kind of moderate finding, quite common nowadays. Many patients have absolutely no symptoms, so we should not be rushing to surgery for an asymptomatic hiatal hernia. We need to ensure that the surgery is going to provide some sort of relief, right? There are many surgeries we do for asymptomatic patients. Colon cancer, breast cancer, lung cancer, those are the obvious ones, right? The treatment is to make sure that that asymptomatic disease does not hurt you. A sliding hiatal hernia that is asymptomatic is unlikely on its own to produce symptoms that the reflux surgery could prevent. However, they should be followed, obviously, by a gastroenterologist should they develop symptoms. Okay. So the treatment of a paraesophageal hernia involves reduction of the complete hernia contents, that is the stomach, any associated other viscera, sometimes you can have colon or even spleen if the hernia is quite massive, back into the abdominal cavity. And you need to excise the hernia sac from the posterior mediastinum and anterior mediastinum. Why? If that hernia sac is still present, scarring will not occur, and you have a much higher likelihood of recurrence of the hernia. Okay, and then the questions are always fundoplication or any anti-reflux operation in the preoperative workup. So for a type 1 sliding hiatal hernia, typically done in the cases of reflux, perhaps some pH testing with a Bravo probe, manometry, EGD, upper, the barium esophagram is a screening study, right? We're looking for any factors that could suggest something more nefarious is going on. The endoscopy will typically also reveal, although to a different extent. I found many times they describe things as just being a hiatal hernia where the barium swallow reveals the entire stomach is within the chest. So again, the similar workup in the outpatient setting amongst these different findings. All right, moving on. So we've talked first about, herniation into the thoracic cavity. Now we're talking about a functional presentation with regards to esophageal dysmotility. All right, so when we have patients, we should be able, from a high resolution manometry, HRM, identify those patterns that are classic for achalasia, DES or distal esophageal spasm, as well as nutcracker esophagus. All right. So there's different numbers that they can give you, and you need to be familiar with them so that you can kind of make that immediate appreciation of what are they trying to describe in this. All right. So integrated relaxation pressures, measure of the gastroesophageal junction during a swallow. So when the LES normally relaxes to allow that food bolus. We talked about the DCI, I will be honest, not something that I look at, but the gastroenterologists do comment on. It's a summation of the contractile force of the distal esophagus. So how well does that distal esophagus evacuate food, right? There's a pause and there's that coordinated relaxation of the LES and the squeezing to get that food bolus completely within the stomach. Diagnosis of achalasia means an integrated relaxation pressure greater than 15 millimeters of mercury, that is absent or impaired, okay, or excuse me, with absent or impaired esophageal peristalsis, all right? On the other hand, distal esophageal spasm, characterized by normal relaxation pressures and early contractions in the esophagus, resulting in this uncoordinated peristalsis and more than 20% of swallows. So this is sometimes that can be seen on a barium esophagram where they say uncoordinated peristalsis, meaning that you're seeing the food bolus, but then there's contraction distal to it as well. Okay. If they comment that there is significantly elevated integrated pressures within the distal esophagus with two swallows that are quite high, as you can see here, 8,000, I think it was closer to 800, then we should be considering nutcracker esophagus. All right. Achalasia, typical bird's beak appearance, right? We have a dilated esophagus. That is not normal, okay? And we have that bird's beak appearance, meaning that there's a failure to relax. So despite we having bolus of food or liquid in the distal esophagus, the LES is not relaxing. Those are the two characteristic findings, all right? Now, usually they're going to be asking questions about achalasia. However, we should be clear that if we see this and they comment something about having done a Nissen fundoplication, that means that they incorrectly performed a Nissen in the setting of esophageal dysmotility. This is a clear thing that can happen where you have a lower esophageal sphincter that cannot relax because Nissen depends on intact motility of the esophagus to get that bolus through, which is not present during achalasia, and thus it can be exacerbated by a Nissen. With a door, the thought is the impact is less. Okay, esophageal rings. Not to be mistaken for the pinching of the hiatus, right? Here we see that we are above the diaphragm, clearly above the diaphragm, but we note on the presence of the barium esophagram a clear indentation that is localized to just above the LES. This would be diagnosed as a esophageal ring. Here's a still present, but it's much more subtle in its indication. On a test, you would hope that they give you this more definitive one and give you the arrows to indicate what we're looking at, okay? This star down here is simply contrast within the stomach. Okay. Esophageal gastric carcinoma, right? Understanding the presence of that tumor as well as the appearance on histologic examination. Venturing a little off course here, because I know you're going to have a subject on the stomach. The appearance of the cells with regards to the neoplasm histologically is important to understand in terms of its origination, right? You guys should be familiar with the Seward class and as well as different treatment of gastric cancer versus lower esophageal cancer. There can be some overlap. However, if you see signet ring cells, gastric origin, much worse prognosis. If you see squamous cell cancer, usually not present so far distally, but typically incredibly sensitive to chemoradiotherapy and would be of esophageal origin, okay? And that's typically because, as you may or may not know, but esophageal cells, that is the mucosal lining, are typically squamous, okay? And they can become columnar with the whole conversion to Barrett's. And so here we see on an esophagram, there is some sort of extrinsic mass resulting in compression and shadowing suggestive of neoplasm. Here again, we see this ruddy kind of just very ill-defined border extending from the distal esophagus into the stomach consistent with a neoplasm. All right, so these are other aspects of a presentation of dysphagia. So whenever you're being questioned about somebody having difficulty swallowing, cancer should come to the forefront of your head. And that's honestly one of the reasons why the barium esophagram is one of the first tests, because it's such an easy screening tool of like, okay, high suspicion for cancer, you should be going down that way. And obviously endoscopy is an easy way to diagnose that as well. All right, moving on. Achalasia. The treatment that has the best outcomes by far, a Heller myotomy with or without a door fundoplication. The reason for the door is because it decreases the incidence of post-myotomy reflux, okay? A poem has comparable outcomes with regards to increased relief of the dysphagia, but has much higher reflux. Why? There's no fundoplication. That's it. However, nowadays, people are much more apt to ask the poem. It's completely endoscopic. You can go home the same day. So polyps are definitely increasing in their incidence and acceptance across both the surgical disciplines and gastroenterology. All right. DES and nutcracker, typically medical treatment. There have been some described attempted myotomy where you literally do a myotomy on the entire esophagus. That is relieving the circular layers of the muscular esophagus for almost its entire distal esophageal length. As you can expect, you have severe dysmotility after that. So again, questionable about whether you're replacing one issue with another and whether it does truly relieve some of those symptoms or not is questionable, but typically medical therapy is recommended as the morbidity of doing the complete myotomy is not advocated for well in the surgical literature. Okay, as we described before, esophageal cancer is something that should be in the forefront of your mind. And treatment for high-grade dysplasia has shifted to endoscopic techniques such as RFA or endoscopic mucosal resection, as well as more submucosal approaches. All right. The main thing that should be identified is with an endoscopic ultrasound, so esophageal endoscopic ultrasound. We need to identify what is the depth of penetration, right? So first of all, when there's high-grade dysplasia, you're not simply doing one area of biopsy, but rather multiple areas, and typically every few centimeters sampling to understand what is the degree, is there any cancer, and any significant nodularity or masses should be biopsied and measured endoscopically to understand the depth of penetration. So anything T1B and higher is treated with esophagectomy because the risk of lymph node metastasis increases significantly. If the T1B lesion, right, how do you know it's T1B? Well, you're probably going to do some attempted endoscopic resection, and if it proceeds beyond the levels of the, submucosal resection, then you're going to proceed to esophagectomy because you have not resected the entire tumor, right? However, many patients nowadays can be treated with very early T1A lesions with endoscopy. Moving on. When a patient is considered having positive or is at risk, any T2 cancers. T2 cancers are typically treated upfront with chemoradiotherapy because there is high suspicion for lymph node metastasis. Okay? Anything that's truly earlier stage and no suspicion for, or if it's a true T1B, esophagectomy is going to be alone with consideration after, in the adjuvant setting, not in the preoperative setting. Okay, so typically identified via endoscopy. That's where the definitive diagnosis and biopsy is going to be identified. If a tumor is presenting with dysphagia, it is almost pathogonomically definitely not going to be an early stage lesion, and therefore should not, endoscopic evaluation is almost unnecessary. And many gastroenterologists nowadays, if there's a large tumor in there, they don't even bother with the EUS, although many still do because they know it's an important part of the staging workup to look for lymph nodes. Why is that? Well, it's simply because they know they're going to have to surgery anyway, and they know they're going to get chemoradiotherapy because by size criteria alone, it's most likely gone below those layers. However, just be aware in the clinical setting, sometimes they simply can't get the probe in because it's so obstructing, the tumor is obstructing. Okay, so biopsies are going to help differentiate symptomatic versus asymptomatic lesions. So the dysplasia that's resulting in early stage disease, Barrett's, chronic inflammation. Have had multiple patients where we see a stricture simply from chronic reflux, biopsying it multiple times, and there's never been any evidence of cancer. Those are the lucky patients because you're clearly concerned with any area of chronic inflammation could result in esophageal cancer. So part of the staging workup, especially for lesions that are smaller, endoscopic ultrasound and CT PET scanning, all right? Any suspicious lymph nodes should be biopsied, although obviously if there's multiple lymph nodes and we have a diagnosed tumor and they're PET positive, we can simply assume, but many times via endoscopic ultrasound, those lymph nodes should be biopsied to confirm the presence of at least N1 disease. If the center of the tumor is at or above the gastroesophageal junction, it's typically classified as a Siewert 1 or 2. If the center of the tumor is 2 to 5 centimeters below the GE junction, it's a Siewert type 3, and it's treated typically as a gastric cancer. Why? When the body of the tumor is on the stomach, you typically have greater threat to spread to gastric lymph nodes, and thus an appropriate D1 lymph node dissection should be considered. Versus if there's only minimal amount of tumor on the stomach, with esophageal disease, we want to be removing more of the hiatal and higher lymph nodes for the drainage, as we're concerned this more in esophageal origin, and we're going to use the stomach as a conduit. So you see the difference. We do resect a portion of the stomach when we're doing esophagectomy, but perhaps it will be inadequate if there's a large burden of tumor on the stomach, and thus it should be a gastrectomy with small amount of esophagus resected versus greater parts esophagus and less stomach being resected. So can always consider that. I've had a number of patients referred to me for an esophageal cancer. In the end, because of the significance of the amount of tumor on the stomach, I ended up referring them to surgical oncology to do the gastrectomy because I felt that they would benefit more from doing that D1 lymph node resection. All right. We've diagnosed esophageal cancer. We've worked them up, and now we're taking them to surgery. The first part of doing esophagectomy, because we always start abdominally, usually, is going to be examining for any aspect of peritoneal metastasis. So the first part is examining the stomach always, looking for any suspicious lesions and getting a frozen section. Similarly, many times in gastric cancer, one of the first things you do, right, is going to be the gastric or peritoneal washings to look for signs of metastasis. So any suspicious looking liver lesions have to be biopsied. If you identify them on the PET scan, they're probably stage 4 already. Those should be biopsied versus via an IR route. However, if you see them and they're superficial to the liver capsule, they should be biopsied as well. You do not proceed with the esophagectomy. It's a contraindication resection. There's no benefit found for doing that. Sometimes a feeding tube and stenting should be considered for definitive radiotherapy. All right. Right. And palliative measures are usually undertaken in those cases. All right. You're proceeding with the esophagectomy. You are creating raw surface area in at least 2 areas. So these patients should not be run dry like typical lung cancer patients. Rather, they should be hydrated for base excess greater than -1. And even more so than with any intra-abdominal anastomoses. Vasopressor agents should be only used if critically necessary. Volume in these patients. Why? So, typically when you're doing a colonic anastomosis or small bowel anastomosis, your perfusing vessels are very close to your anastomosis. They are typically very far at the edge of your esophageal conduit that you've created with the stomach, right? You want to preserve at least 2 vessels so that the degree of hypoperfusion is less, and you want to keep that blood pressure as high as possible, okay? When I was in the laboratory, we had developed an intraoperative pulse oximeter in order to determine, have we adequately perfused the distal, aspect of the esophageal conduit. I can tell you we eventually aborted because after, studying about 50 patients, we determined that the average pulse oximetry was between 40 and 60%. And thus, we never achieved anything that would be considered like a well-perfused colon, which is in the region of, as you would expect, like 90 to 100%, right? So there is always, in almost every esophagectomy, hypoperfusion. And there's many surgical techniques, but you want to maintain careful handling of the stomach. Many times people sometimes even want to supercharge stomachs if they bring them to the neck by attaching some of the neck vessels. That's been done recently as well to good effect, especially when doing like a substernal reconstruction of the esophagus. And again, we're kind of the right gastroepiploic and the right gastric arteries to the stomach are typically those that are preserved. Some people go so far as to preserve some of the more proximal left-sided vessels as well, and just transect the top aspect of the stomach in order to create that conduit as kind of like a sweets anastomosis just at the hiatus. So hypotension wants to be avoided. Vasopressor can exacerbate gastric tip necrosis, which of course, oh, sorry for the name there, but crystalloid, especially intraoperatively and postoperatively. And that's typically been the reason for why patients remain intubated after this procedure. Nowadays, we desperately try to extubate them as quickly as possible. And vasodilation, if a patient has a high, long-standing history of hypertension and are noted to be hypertensive postoperatively, continue to resuscitate them adequately. Do not focus on, blood pressure lowering medications. I can tell you my own experience that can result in a deleterious effect of the conduit by lowering perfusion pressures within the conduit. And sometimes you have to look for the reasons in that patient for possible leaks, right? Because it's a very, 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 very low bar to cross. And so let's say your white count is normal, there's no evidence of acidosis, but the patient is persistently tachycardic, raising a suspicion for anastomotic leak. There's an esophagectomy. That is enough of a reason to look every day to rule out that anastomotic leak. Okay, so the esophagus can be accessed from the left neck, right chest, and left chest for the distal esophagus. The different approaches obviously being a McEwen 3-hole esophagectomy, typically with a neck anastomosis. The Ivor-Lewis is going to be the right chest and abdomen for a mid-thoracic anastomosis. In addition, a left thoraco-abdominal incision, so that's going to have a left neck incision, an incision that goes between the stomach, between the chest and the abdomen, which also gives you better access for, again, lower distal esophageal. You have to go through, if it's a mid-esophageal tumor, you have to go in through the right chest. And if it's a higher lesion, again, above 23 centimeters, above even 24 centimeters, you want to consider chemoradiotherapy, mainly because you're going to be dissecting tumor perhaps away from cervical esophagus, which can make reanastomosis challenging. Okay, so we are, in terms of the mid-esophagus supplied by the aorta, proximal esophagus, inferior thyroid artery, distal esophagus is going to be left and gastrophrenic arteries. Lymphatic drainage is longitudinal, so the distal esophagus is primarily to the celiac nodal basin, and the mid portion is primarily the mediastinal and para-aortic nodes. Okay, so we've done an esophagectomy. What are some signs of leak? Tachycardia or tachyarrhythmia. So the patient is doing well, however, has just had the onset of atrial fibrillation. Despite the fact that that could simply be a risk of having thoracic surgery, we need to rule out leak. So atrial fibrillation, though common, can be a sign of leak. Why? Because the effluent, the mediastinitis, is irritating the left atrium, which makes it thus more irritable and susceptible to atrial fibrillation. Prompt intervention is always the minimum in these settings, right? Urgent CT scans with oral contrast or even just endoscopy to identify the leak if the patient is stable. If the patient's unstable, then we have to figure out, why that's going on. If you see in a chest tube the same contents as are visualized in the nasogastric tube, that is an esophageal emergency. We have to go back to the operating because you have a massive leak that's going to result in mediastinitis, right? One of the main reasons why people do neck anastomoses is because there's less chance of all that oral and gastric contents going into the chest. Mediastinitis can be lethal. A neck wound, that's a superficial infection, right? You can drain into the neck, and there's much less chance of having a surgical emergency. Many times, because of my training, we did so many open esophagectomies, we simply opened the neck, sometimes even at bedside, and placed a vac drain there, which will resolve that leak, rather than needing to place a stent, etc., for the mid-Ivor-Lewis approaches. Okay, most commonly, especially for Ivor-Lewis, and if you've used an Orval anvil, it's a smaller anastomosis. Thus, you can place a stent ensure you have good wide pleural drainage. If there's any development of empyema from the incredible amount of secretions in the chest, empyectomy or a decortication should be considered to address and hopefully close or widely drain that area. Okay. If there's such significant necrosis of the gastric conduit, right? The stomach is dead. Now you have just wide leakage. You have to control the leak. So you're going to take down that conduit, shove it back in the stomach, and you're going to bring out and do a spit fistula, right? You're saving the patient's life. And you're going to come back another day to do a substernal reconstruction. Hopefully you have enough stomach. If not, you're going to need different conduit, such as colon or jejunum, and doing a substernal approach. Why? That's still a internal thoracic, but extra pleural approach to bringing that conduit up and allowing them to once again be able to swallow. All right, other aspects of the esophagus. We have a Zenker's diverticulum. It's typically posterior, proximal to the cricopharyngeal muscle. That's critical of understanding because it has to be resected. All right, but it results from a hypertonic cricopharyngeus. So it's a pulsion diverticulum. Traction diverticulum occurs typically within the mid-esophagus, and it's usually like you have histoplasmosis within the lymph nodes, chronic inflammation, and it can cause this kind of traction pulling, resulting in a diverticulum there. Epiphrenic diverticulum, as you would expect, epiphrenic by the diaphragm, is going to occur in the distal third of the esophagus. It's another pulsion diverticulum, typically associated with esophageal body motility disorders. Thus, in treatment of an epiphrenic diverticulum will typically involve a myotomy. So you'll be doing a Heller myotomy in addition to the resection of the diverticulum. Sometimes the myotomy alone, if the diverticulum is small enough. Okay, so if a patient has an epiphrenic diverticulum that's, say, 4 centimeters or more, we should be going to a Heller myotomy that can treat that diverticulum at the same time. If it's a small 1 to 2 centimeter epiphrenic diverticulum, a POEM could be considered, all right, because you're doing the definitive treatment of that diverticulum, right? The diverticulum is occurring because there's a failure to relax of that sphincter. Okay, going to venture off a little bit into lung cancer briefly. So we have an 80-year-old patient with a peripheral lung nodule, okay? Once you have a lesion here, we see a nearly 3 centimeter lesion at the apex, high suspicion for a cancer, especially if they have a smoking history. We're going to move to a PET scan as part of the clinical staging, either before or after the biopsy. What are the main ways of diagnosing this, right? We're going to perform either a transthoracic approach, so a IR needle biopsy, which is really falling away mainly due to the fact that patients hate getting stabbed in the chest with a needle, as any normal person does, and the fact that we have very comprehensive methods. Here you can see there's literally an airway going right into the lesion. Thus, a robotic bronchoscopic approach is going to help get you into that lesion, get all the tissue you need for a diagnosis, as well as permit staging within the mediastinum, which is the critical thing that needs to be done. Why? Because we know that when there's N2 or N1 disease, there are patients who are now candidates for neoadjuvant chemotherapy, and neoadjuvant chemotherapy can result in improved progression-free survival for patients. Okay, so what are the critical stations that we have to understand? So here we have kind of the, it's a cartoon, but we're kind of going down the trachea. Here you can see that when we're peeling off the esophagus, it would be very gentle, right? Because you're right on the membranous portion. They're really adjacent. So it's quite easy for tumors, if they have a tumor in the esophagus, to create a TE fistula, which is a critically bad problem for patients, right? So we're coming down. What are the critical lymph node stations that we want to identify for preoperative staging? That is 4R. So on the right side, adjacent to the azygous vein, 7, which is a subcarinal station, and 4L, which is just above the aortic arch or just adjacent to it, okay? Or immediately inferior to it. All right, so what do those look like? Here are some of the ultrasound images. 4L, we see it's lying between the two aspects of the aorta right here, okay? Level 11, this is going to be down at this crux. So where the lower and upper lobes of the left side branch off, right here is going to be a level 11L. Okay, level 10 is going to be proximal to that. Okay, level 7, we're looking right here at a lymph node here. You can see what the needle looks like going into it. That's at the carina right here. And this is using an endoscopic ultrasound. And finally, 4R. All right, here's the lymph node identified right there with a needle inside of it. Here's a much bigger blown up view, biopsying a suspicious looking nodule. Okay, some additional presentations within lung cancer. Okay, here we see a patient who's a smoker, presented to our practice with small volume hemoptysis. So small volume is going to be like blood streaked sputum, right? Just coughing up and there's notions of blood with it. Massive hemoptysis, 200 milliliters or more. So that's less than a quarter cup. It's not much. That is massive hemoptysis. That is a surgical emergency. So small volume, blood streaked sputum, definitely needs to be evaluated, but it's not the emergency that the other one is. Okay, so what do we do in this? Bronchoscopy. And what do we see? We see a tumor that is endobronchial. And most commonly, this would be a carcinoid tumor. Why? Well, it's vascular, it's pedunculated, it has a smooth covering, right? Squamous cancers, which are also going to be more proximal as this one is, are going to have a much more irregular appearance in this tumor. All right, so we're going to surgery. What do we need to do in evaluating the patient? We want to evaluate their exercise physiology, that is their respiratory physiology, so cardiopulmonary assessment. Okay, so as you would expect, if you get short of breath and I remove a portion of your lung, you're going to have an exacerbation of that shortness of breath. Why? Removing lung tissue is going to increase that mismatch of pulmonary reserve, resulting in increasing cardiopulmonary exercise tolerance, right? Or decreasing cardiopulmonary exercise tolerance. So pulmonary function testing, the patient's not exercising. It's just a measure of the overall function of your lungs. A true functional measurement, okay, is going to be CPET or CPEX. That's basically putting you on a bike, measuring your inspired oxygen, your expired carbon dioxide to develop your VO2 max score, right? Milliliters per kilogram per minute. Anything greater than 20 on a CPET is excellent. There's surgery all day long, okay? 15 to 20, some intermediate level risk still appropriate for a lung resection. 10 to 15, increased risk, maybe consider alternate measures. Finally, less than 10, VO2 max, avoid surgery at all costs. Patient is at risk for prohibitive level of complications, okay? Excuse me. Robotic minimally invasive surgery. The main aspects of surgery that result in the complications from a thoracic perspective is the pain. We have the worst pain amongst all the surgical disciplines because every breath hurts. Minimally invasive surgery with a robotic approach increases your pool of candidates because there's less morbidity, there's less pain, increased ability to control that pain. All right, that's been a mouthful. I'll pause for any questions that you guys may have at this point. Thanks so much for the privilege of presenting to you. I hope it was worthwhile. Remember, questions, questions, questions. Look at the pictures, understand why the questions are wrong. Good luck. Tien.
Thank you, Dr. Kachala. So is there any questions for Dr. Kachala?